1. Which of the following cephalometric measurements is most useful for assessing the anterior-posterior position of the maxilla relative to the cranial base? A. SNB. B. SNA. C. ANB. D. Wits appraisal. 2. In a Class II Division I malocclusion, which of the following characteristics is most commonly observed? A. Anterior crossbite. B. Procklined maxillary incisors. C. Retroclined mandibular incisors. D. Posterior open bite. Three. Which appliance is most effective for correcting a skeletal anterior open bite in a growing patient? A. Holly retainer. B. High pull headgear. C. Forceps appliance. D. Lip bumper. 4. Which tooth movement is most likely to cause root resorption? A. Intrusion. B. Torque. C. Rotation. D. Tipping. 5. In a panoramic radiograph, the ghost image is characterized by all of the following except A. Appears on the opposite side of the image. B. Is magnified. C. Appears clearer than the real image. D. Is higher on the film. 6. The primary goal of a functional appliance is to A. Retract anterior teeth. B. Modify skeletal growth. C. Expand dental arches. D. Correct crossbites. 7. In orthodontics, the Frankfurt horizontal plane is defined by which landmarks? A. Nasion and bion. B. Porion and orbitali. C. Sella and nasion. D. ANS and PNS. 8. Which of the following factors is most associated with a high mandibular plane angle? A. Long anterior facial height. B. Deep bite tendency. C. Strong chin projection. D. Decreased lower facial height. 9. The primary purpose of a transpalatal arch is to A. Expand the maxilla. B. Control molar rotation and tipping. C. Correct crossbites. D. Maintain space. 10. Which of the following describes the biological basis of orthodontic tooth movement? A. Deposition of enamel. B. Bone remodeling via pressure and tension sides. C. Dentin apposition. D. Pulpal response. (11) The ideal position for maxillary incisor display at rest is typically A. No incisor display. B. 2 to 4 millimeters. C. 5 to 6 millimeters. D. 7 to 8 millimeters. (12) In terms of root resorption risk, which of the following is least likely to contribute? A. Heavy continuous forces. B. Genetic predisposition. C. Light intermittent forces. D. Prolonged treatment time. (13) Which type of malocclusion is typically indicated for early treatment or phase 1? A. Mild crowding. B. Posterior crossbite with functional shift. C. Class 1 with open bite. D. Minor spacing. (14) For an adolescent patient with mandibular deficiency, which appliance is most appropriate? A. Quad helix. B. Herbst appliance. C. Nance appliance. D. Rapid palatal expander. (15) Which of the following is not a characteristic of a Class 3 malocclusion? A. Negative overjet. B. Convex facial profile. C. Anterior crossbite. D. Mesial step molar relationship. (16) In the absence of growth, which option is best for correcting a skeletal Class 2 malocclusion? A. Functional appliance. B. Orthognathic surgery. C. Headgear therapy. D. Lip bumper. (17) The most common cause of relapse after orthodontic treatment is A. Root resorption. B. Improper retention. C. Gingival overgrowth. D. Bone dehiscence. (18) Which imaging technique is most appropriate for evaluating temporomandibular joint disorders? A. Bite wing radiographs. B. MRI. C. Panoramic radiograph. D. Cephalometric radiograph. 19. Which of the following best describes the curve of SPE? A. Buccolingual curvature. B. Curve of the dental arch in the frontal plane. C. Anteroposterior curvature of the occlusal plane. D. Vertical overlap of anterior teeth. (20) The primary mechanism of action for a rapid palatal expander is A. Alveolar bending. B. Mid-palatal suture separation. C. Dental tipping. D. Compressive force. (21) A patient with a skeletal open bite most likely presents with A. High mandibular plane angle. B. Anterior tongue posture. C. Short lower facial height. D. Deep bite tendency. ABO. The American Board of Orthodontics, or ABO, is the oldest and most prestigious specialty board in dentistry, founded in 1929 to elevate the standards of orthodontic care and promote excellence in the field. As the only certifying board recognized by the American Association of Orthodontists, or AAO, and the American Dental Association, or ADA, the ABO's mission is to protect the public by ensuring that orthodontists possess the knowledge, skills, and proficiency required to provide the highest quality of care. The board certification process involves a rigorous, voluntary examination that tests clinical expertise and comprehensive treatment planning capabilities. This process includes both a written examination, assessing theoretical knowledge, and a clinical examination, which involves case presentations demonstrating diagnostic skills, treatment outcomes, and adherence to ethical standards. Orthodontists who successfully complete these requirements earn the distinction of being ABO certified, a mark of dedication to lifelong learning and commitment to excellence in orthodontics. Here are 5 top beneficial uses of ABO. 1. Ensuring high standards of care. The ABO certification process upholds stringent standards for orthodontic practice, ensuring that certified orthodontists possess advanced clinical skills and knowledge. This benefits patients by guaranteeing high quality and effective treatment outcomes. 2. Promoting continuous professional development. ABO certification is not a one-time achievement. It requires orthodontists to participate in continuing education and periodic recertification. This commitment to lifelong learning helps practitioners stay updated with the latest advancements, techniques, and research in orthodontics. 3. Enhancing professional credibility. Earning ABO certification serves as a mark of distinction, demonstrating an orthodontist's expertise, professionalism, and dedication to excellence. This can boost patient confidence and trust, as well as differentiate certified practitioners in a competitive field. 4. Providing objective assessment of clinical skills. The ABO's rigorous written and clinical examinations objectively assess an orthodontist's diagnostic abilities, treatment planning, and clinical outcomes. This ensures that certified orthodontists have met or exceeded national standards of competence. 5. Educating and protecting the public. By maintaining a public directory of ABO-certified orthodontists, the ABO helps patients make informed choices about their care providers. This transparency fosters public trust and emphasizes the importance of receiving treatment from certified specialists.